we'll get started in the interest of time. Historically, we have about 25 to 30 people in active attendance, and then once we post the video on YouTube, on our YouTube channel, through the New York Section website, we're getting up to 1,000 views on many of these lectures. So even if the cohort that joins us this evening is relatively small, it is not a reflection of the true impact of the educational experience you're providing to all of our residents who are preparing for their in-service on the 21st of November. I'm Gina Bottolato. I work at Columbia, and it's my pleasure this evening to welcome Dr. Fatima Husain, who is also an NYPH employee. She's at Cornell. Dr. Husain is a New Jersey native. She attended Rutgers Medical School and actually earned her MPH prior to graduation from medical school. She attended Mount Sinai for her residency training in urology, and then went on to do a fellowship at USC in advanced robotics, laparoscopy, and urologic oncology. And she specializes in urologic oncology and reconstruction. And she has a big task in front of her this evening, because she's going to be talking to us about infections of the urinary tract, including urinary tract infections, Fournier's, sexually transmitted diseases, emphysematous infections of the kidneys, and XGP. I'm going to hand it over to Dr. Husain. As our protocol, just save any questions you have towards the end. You can post your questions in the chat, and then I can pose them at the end of the lecture. And also check out the chat box, because it does have a survey for those of you that are participating in Empire the last 2 months. We do appreciate your input. So take it away, Dr. Husain.
All right. Hello. Thank you for the introduction. I am an attending at Weill Cornell, New York Presbyterian. I'm actually interested in this topic. Yeah, I'm oncology trained and robotic trained, but everyone will treat some sort of urinary tract infection. And over the past week or two, I feel like I've treated a lot of infections that I'm presenting on. It was almost like the urology gods knew I was up for this presentation. The way that I'll present is I'll try to just kind of do a systematic starting from the top of the urinary tract and making our way down. We can just follow along kind of urinary tract. So starting with the kidneys, pyelonephritis, something that we've all seen and treated, has a classic triad of flank pain, fever, CVA tenderness. The most common, I try to keep abbreviations on things, so it's an easy, quick review, a day or two prior to your exams. This is pretty high yield stuff, and it's easy. Give me questions for your in-service exam and also for your board exam. So most common cause of pyelonephritis, E. coli. There's certainly other bacteria that cause it, but that's the most common. Imaging is not something that's necessarily indicated. Remember, pyelonephritis is a clinical diagnosis, not so much an imaging diagnosis, even though you'll see the radiologist read signs of pyelonephritis. Imaging is indicated if it's a complicated pyelonephritis or it's an unresolving pyelonephritis, in which case you want to do a CT scan to rule out an abscess as a complication of the pyelonephritratis. Most commonly on CT scan, you'll see a delayed nephrogram, and oftentimes you'll see this wedge-shaped area. Ultrasounds can demonstrate pyelonephritis, but really CT scan, if you're going to image, is the way to go. If there's obstruction in the setting of pyelonephritis, obviously you're going to stent them and have the interventional radiologist place in a nephrostomy tube. It can be managed on an outpatient basis in healthy individuals, usually with PO antibiotics. Depending on what the culture shows, you can consider starting them on giving an IM or an IV antibiotics dose prior to starting the oral antibiotics. Usually we start with fluoroquinolone or Bactrim, and of course, if there's gram-positive bacteria, Augmentin. In the case of uncomplicated, unresolved, or inpatient pyelonephritis, of course, we start with IV antibiotics, broad spectrum until you have a culture to go by. Generally, we keep them on IV antibiotics until they're clinically improving. Usually, I tell them you tell medicine teams once they've been febrile for 24 hours and their leukocytosis is improving or resolved. For pyelonephritis, the follow-up is a repeat urine culture about 2 weeks after completing antibiotics. Of course, like I mentioned before, if they're not improving on antibiotics, whether it's oral or IV, you do want to consider imaging, CT scan with IV contrast to rule out an abscess. UPEC, Uropathogenic E. coli, it's a common pathogen that causes urinary tract infections. This E. coli has P. fimbriae, that's the virulence factor of how it attaches to urothelial cells, and then of course ascends up the collecting system. Renal abscess, it's most commonly caused by gram-negative bacteria. It can be associated with stones, pyelonephritis, reflux, of course, complicated UTI, and also from hematologic spreading, so IV drug use, recent dental work, or skin infection. Again, CT with IV contrast, you'll see that sharply kind of marginated area with the hypoattenuation. And then really management depends on the size of the abscess. So usually less than 3 centimeters can be managed with IV antibiotics alone. 3 to 5 centimeters or an abscess that's less than 3 centimeters, which is failed conservative therapy. At that point, you IV antibiotics, and then you'll have percutaneous drainage. And of course, larger abscesses, of course, percutaneous drainage, IV antibiotics. If that does not work, open surgical drainage, and rarely does it get to the point where you need nephrectomy. XGP kidney, we've all seen it. It's a chronically inflamed kidney with destruction of the renal parenchyma. It causes loss of renal function and most commonly caused by E. coli and Proteus. Very commonly associated with stones, diabetes, patients that are immunocompromised, and fistulas with surrounding organs, so renal colic, colonic fistulas. It's more common in females, and the pathologic kind of histologic finding is those xanthoma cells, the lipid-laden foamy macrophages. On CT imaging is the classic bear paw sign. So you'll see the dilated kind of hypoattenuating lesions with this small thin rim of enhancing parenchymal tissue. It's supposed to kind of mimic the toe pads on the bottom surface of a polar bear's paw. The kind of standard of treatment for management, IV antibiotics, percutaneous nephrostomy tube, and nephrectomy, it's not the immediate treatment plan, but obviously, seeing how they respond to antibiotics, repeat imaging, any collections or adding as many drainage tubes as necessary can help save some renal function. And then ultimately you'll be kind of deciding if there's enough renal function left to treat the stone and preserve the kidney, or if there's not much renal function left behind, and a delayed nephrectomy would be indicated at that point. And emphysematous pyelonephritis is a gas-producing bacterial infection of the renal parenchyma. It's actually considered an emergency, very commonly associated with diabetics, common pathogens, E. coli, Klebsiella, and Proteus. For CT imaging, there'll be gas within the renal parenchyma. And there's actually 2 types of emphysematous pyelonephritis. Type 1, greater than 1/3 of the renal parenchyma is destroyed. There's no really intrarenal or extrarenal fluid collections, and this one actually carries the highest mortality rate, about 70% of patients. Type 2, emphysematous pyelonephritis, you'll see more of a presence of the intrarenal and extrarenal fluid collections, and there's a lower mortality rate, about 20% in patients with type 2. So treatment, of course, is a sepsis protocol, aggressive fluid resuscitation, broad spectrum IV antibiotics. Sometimes these patients need to go to the ICU. Sometimes they need vasopressors. Obviously, type diabetes, glucose control is so important. Percutaneous drainage, IV antibiotics, and then of course, nephrectomy in patients who don't respond to treatment. And a lot of times this is in those type 1 emphysematous pyelonephritis patients who have a higher mortality rate. In infected renal cysts, we've all seen patients with adult polycystic kidney disease and acquired cystic disease. In patients who present with this, usually flank pain, fevers or chills, and urine cultures are often negative. It's hard to differentiate on CT scans if it's an infected cyst versus a hemorrhagic cyst versus a pertinacious cyst. Really have to go based on clinical picture, the patient, and the standard of care, of course, is lipophilic antibiotics which penetrate the cyst walls. And in cases where you're unable to clear the infection, percutaneous drainage is indicated. There's a few slides that I've included that I'm not going to go into detail for, but they're kind of lower yield questions, which certainly fall within the family of, GU infections. So I'll just kind of go along past a few of those. Moving now to the ureter and collecting system. Emphysematous, we've spoken about emphysematous pyelonephritis. Emphysematous pyelitis is a gas-producing infection of the actual renal collecting system. Again, the most common bacteria that you'll see for this is E. coli and Klebsiella. And as this is air within the collecting system, as opposed to emphysematous pyelonephritis, which is gas within the parenchyma. The standard of care is, treating broad spectrum IV antibiotics, and sometimes the stent is indicated. And the last patient I had with this, we managed conservatively, and she did great with just IV antibiotics, and nearly all will recover. Infected hydronephrosis is hydronephrosis in the setting of UTI, and a lot of times you'll see pyonephrosis, which is an infective hydronephrosis with debris. Causes destruction of the renal parenchyma, and the ultrasound you'll see this kind of echogenic collecting system with debris. In this case, not only antibiotics indicated, but some sort of drainage, whether it's a stent or a nephrostomy tube. And in the case of complete obstruction, you can have a negative urinalysis and urine culture. Bladder, cystitis. We've all seen it. We've all treated it. The most common pathogen for this is E. coli. Of course, in young sexually active women, Staphylococcus saprophyticus is a very common agent. There's uncomplicated cystitis, and of course, there's complicated cystitis in the case of GU tract, abnormalities or anomalies with the urinary tract, immunosuppression, diabetes, cirrhosis, pregnancies, considered complicated UTI, the hospital acquired or after one of our urologic procedures. And diagnosis of cystitis is, of course, a positive UA symptoms. And a straight cat specimen of greater than 10 to the third bacteria count, or in a midstream catch 10 to the 5th. Very important terminology, and you'll see this as you get into practice, as you get referrals for recurrent UTIs, because it's important to differentiate what a patient is coming to you for. Unresolved infections are that the initial antibiotic course or treatment didn't eradicate the infection. So maybe it was a resistant bacteria. Recurrent infections are 2 or more culture-proven infections within 6 months, or 3 or more within one year period of time. Reinfection means a repeated infection after clearance with the same bacteria or a different bacteria. Persistent infections are just inability to clear despite a bacteria, despite culture-proven, culture-specific antibiotics, and of course, cavities, which are most commonly from meatal bacteria. Asymptomatic bacteria, very common referral, especially in postmenopausal women that you'll see in the office. So it's a positive urine culture in asymptomatic patients. not necessarily have to give antibiotics. In fact, I'm very conservative with antibiotics. Certainly a population that you do have to be careful about, and we do recommend starting on antibiotics is pregnant patients, because they have a higher risk of A, pyelonephritis, and B, preterm labor. So if they have asymptomatic bacteriuria and a properly collected specimen, do start them on daily prophylaxis. Treatment for cystitis, first-line drugs. This is straight off the AUA's guidelines on this. Macrobid, Bactrim, or phosphomycin. Fluoroquinolones come in as a second-line therapy. And for uncomplicated urinary tract infections in women, it's the standard treatment is a 3-day course. Of course, in men, it's 7 days. Complicated urinary tract infections, common looking at like immunocompromised patients, renal transplant patients. It's slightly longer course of antibiotics, and you can start with IV antibiotics. If there's any question of bladder outlet obstruction, older men, BPH, of course, Foley to help relieve the obstruction. For uncomplicated reinfections, you can consider a low-dose daily antibiotic prophylaxis, or in patients who are reliable, you can allow them to self-treat themselves with antibiotics. Vaginal atrophy, estrase and intravaginal estrogen is great for these patients who have recurrent infections in the setting of vaginal atrophy. It's been shown to reduce the risk of symptomatic infections. And of course, uncomplicated reinfections after intercourse, you can give patients postcoital prophylaxis. And young women do not necessarily have to do repeat urine culture after they've taken their antibiotics. In elderly patients, in men, in symptomatic patients, you do want to repeat their urine a week or two after they've completed their antibiotics to make sure they've cleared. And of course, in patients who have recurrent infections or complicated infections, aside from repeating their urine, you do want to do your workup in terms of upper tract imaging to identify any anomalies, stones, and even cystoscopy to evaluate for bladder outlet obstruction. So Emphysematous Cystitis is a gas-producing bacteria resulting in air in the bladder wall, most commonly caused by E. coli and Klebsiella. Of course, diabetics are most at risk of this. Differential diagnoses, recent urologic instrumentation, whether it's catheterization, cystoscopy, or even enterovesical fistula. Standard treatment is catheter drainage, antibiotics, and of course, going back to the same diabetes and glucose control. Schistosomiasis, important for us to know, rare, but important for you to know because of its risk of leading to bladder cancer, specifically squamous cell cancer of the bladder. Again, slower yield stuff that you can look at later on. Candiduria, fungal infection, the urinary tract. There's different kind of candida that are that you'll see, albicans, cruzi, and glabrata. Again, going back to immunocompromised diabetic patients with chronic indwelling Foley catheters, with chronic stents. The urinalysis usually shows budding yeast, pseudohyphae. I usually will get the infectious disease, my infectious disease colleagues involved for these patients because the specific seroforms of the candida are sensitive to the fluconazole family, the azole family, and some are not. And a lot of times the infectious disease doctors can weigh in and help manage these patients who can be sometimes difficult to manage. Moving down to the genitals, Fournier's gangrene. It's actually one of my favorite things to operate on. It's very satisfying. It's a polymicrobial necrotizing fasciitis of the perineum and the genitals, most commonly associated with diabetes and alcoholism. It can have a urogenital source versus an anorectal infection and can be associated with the presence of a urethral stricture. It progresses rapidly. A lot of times you can feel the crepitus. You can see, the skin that's necrosing. You can see the erythema. It's considered an emergency. CT imaging is not necessarily indicated, but it can help guide you in terms of the extent of disease. And essentially, it's a polymicrobial organism infection. It causes ischemia, fascial necrosis, and obliterative endarteritis. Of course, the standard of care is taking the patient to the operating room for aggressive surgical debridement, broad spectrum IV antibiotics. Usually these patients go back to the operating room within 24 to 48 hours for a second look, a washout, further debridement. If the testicles need to be exposed as part of the scrotal debridement, you can create thigh pouches for these individuals. Usually we start with wet to dry dressing, sometimes with saline, sometimes with Dakin solution. And once the infection and the wound bed starts looking healthy, you can consider a wound vac placement to reduce the healing time. It really helps with forming that really nice granulation tissue and helping the wound close from the inside out. 1/3 of patients will die from Fournier's gangrene, and a majority of these are diabetics. Prostatitis, most commonly caused by intraprostatic ductal reflux of urine into the prostate. It can also be associated with phimosis, unprotected anal intercourse, condom catheters, and even transurethral surgery. The most common bacteria is E. coli. Of course, there are other bacteria that cause prostatitis. Most commonly, the symptom presentation can vary: suprapubic pain, testicular pain, perineal pain. On exam, they have their hot, boggy prostate. Of course, you want to limit the amount of prostate exams that are happening. There is a risk of worsening sepsis. You certainly do not want to do a PSA at this time. Urinalysis, urine culture, and blood cultures if they're presenting with sepsis. Standard of care is, of course, antibiotics, alpha blockers, and anti-inflammatories. If there's a concern of bladder outlet obstruction, you really want to avoid indwelling Foley catheter placement. You can consider intermittent cath or a suprapubic tube placement. If a patient does not clinically improve, after culture-specific antibiotics, that's the time to consider CT pelvis imaging to rule out an abscess. Of course, abscesses can be managed with percutaneous drainage or transurethral unroofing. And really, you see this when the infection's been lingering for a while or in immunocompromised individuals. Many different types of prostatitis. There's acute bacterial, there's chronic, and of course there's inflammatory and non-inflammatory chronic pelvic pain syndrome, non-infectious causes. We commonly will treat type 1 and type 2, and we will certainly get referrals for chronic pelvic pain syndrome. Post-prostate biopsy infection is most commonly caused by increasing fluoroquinolone resistance. Very important to look at get a urine culture pre-biopsy, but also to look at your local area's antibiotic nomograms to see, what this fluoroquinolone resistance patterns are, and even for other antibiotics that you potentially will use pre-biopsy. Orchitis and epididymitis. There can be bacterial, viral, parasitic, or even caused by tuberculosis. A majority of patients will have both epididymitis and orchitis. If it's just orchitis, more likely to consider a viral etiology. In young boys and older men, it's usually associated with urinary tract infections. The most common bacteria is E. coli. In young sexually active men, it's most commonly associated with sexually transmitted diseases. About 70% of cases by chlamydia, 30% of cases by gonorrhea. For someone who presents to you for urtitis, of course, diagnosis, you're going to be doing a urinalysis, urine culture in young males, even older males. STD or STI screening is important. We'll treat with antibiotics, anti-inflammatories, analgesics. In young males, given the risk of, given most commonly caused by gonorrhea and chlamydia, we treat with ceftriaxone and doxycycline. These orchitis can be complicated by a pyocele, which is an infectious collection between the layers of the tunica vaginalis. Differential diagnoses can be a reactive hydrocele or a hematocele, you can tell by ultrasound. Of course, if the patient's clinical exam's not improving, these can kind of progress to Fournier's gangrene. So, in the case that a patient's not improving clinically, ultrasound is showing a collection, is definitely worth your while to have either to do an IND and drainage. Epididymitis in the pediatric population is most commonly a viral etiology, and so it's mostly supportive care with analgesics and ice packs. For acute bacterial, again, usually urinary tract infection or sexually transmitted disease infection, you'll see hyperemic flow on ultrasound. And again, the treatment usually is based on the patient's age group. So less than 35 years old, you're treating for a suspected gonorrhea and chlamydia, and for greater than 35 years, you're treating for suspected urinary tract infection, bacterial. Amiodarone is a medication that can cause drug-induced epididymitis, and usually you can either decrease the dose of the medication or stop the medication altogether, and that can resolve the epididymitis. Again, these are kind of lower yield infections that you'll see, and you might get questions on, but lower yield that you can look at a later date. GUTB, something that you will see. So the most common extrapulmonary sites of a TB are 1, the lymph nodes, and 2, the urinary tract. Most commonly you'll see on urinalysis sterile pyuria, microscopic hematuria, and diagnosis is with 3 consecutive early morning urine specimens for acid fast and mycobacterium culture. GUTB treated commonly how we would treat pulmonary TB. This is a good time to get your infectious disease colleagues involved. And different parts of the urinary tract can be affected in different ways from GUTB. So in the kidneys, you'll see these renal calcifications. You'll see the classic moth-eaten calyces. Ureters will typically have stricture. The bladder can become small and non-compliant. Calcifications can be seen in the prostate and the seminal vesicles. You can get granulomatous epididymitis. Kind of treatment for TB is not only medications, but in the case of renal TB, if it's a non-functional kidney or there is extensive disease, and of course if there's coexisting renal cell carcinoma, that's an indication for nephrectomy. Strictures can initially be managed with a stent or a nephrostomy tube. Then you can start the patient on tuberculosis medications, even steroids. If there is no improvement in the stricture at that point, you can consider reimplantation or dilation of the stricture. And of course, if you have a non-compliant contracted bladder, that would be a time to consider bladder augmentation. So sexually transmitted diseases, you will see them, you will treat them. And I literally in the past 2.5 weeks have treated every STD that I'm going to present on, even trichomonas, which I thought was interesting because I haven't seen that in a long time. STDs, there's 20 million new STD diagnoses every year. There are higher risk groups, usually adolescents and young adults, racial and ethnic minorities, and of course, men who have sex with men. History and physical exam is very important as part of your history and physical. And of course, counseling. As a urologist, we're counseling a lot to patients about prevention and protection. Urethritis, there's two types, either gonococcal or non-gonococcal. And the the diagnosis is most commonly through nucleic acid amplification and PCR of either urethral discharge or of the urine. Urethritis caused by chlamydia, there's a few serotypes, D through K. The incubation period is about 3 to 14 days. Most patients are asymptomatic. If they do present, most commonly with a clear white urethral discharge, most women are asymptomatic, and it's important to diagnose this because 40% of women, in 40% of untreated women, this can lead to pelvic inflammatory disease. The treatment for chlamydia trachomatis is azithromycin, 1 gram times once, or you can give them doxycycline, and you are going to empirically treat for gonorrhea at the same time because many times chlamydia and gonorrhea co-infect together. All sexual partners must be treated. Gonorrhea has an incubation period of about 2 to 14 days, and different from chlamydia. Chlamydia has more of a clear white discharge. This has more of a mucopurulent urethral discharge. Again, most men are asymptomatic. And we're looking at either urine or urethral testing. Again, all sexual partners need to be treated. You're treating for both gonorrhea and chlamydia at the same time. Disseminated gonococcal infection requires hospital admission. We'll treat with ceftriaxone daily. Again, nice time to get your infectious disease colleagues involved. Other bacteria that can cause urethritis are ureaplasma and mycoplasma. And these are treated either with azithromycin, which is what I usually start with. And if they don't respond or they have persistent infection, I'll go on to treat them with doxycycline. Cervicitis, vaginitis, kind of same thing, most commonly caused by chlamydia and gonorrhea. They can lead to pelvic inflammatory disease. We don't typically see or treat this. It's mostly goes to the gynecologist, but certainly we might see or treat it. And so again, all sexual partners in the preceding 60 days need to be treated. It can be treated with IM and oral antibiotics. In the case of severe symptoms and presentation, these patients are hospitalized and started on IV antibiotics. This kind of summarizes what I mentioned in the last few slides. This is again straight off of the AUA's website. Ulcerative lesions of the urinary tract. Herpes, there's type 1 and type 2. Usually these are painful ulcerations. Multiple vesicles with an erythematous base. These vesicles might coalesce into one larger lesion. The initial presentation, they can present with these flu-like symptoms. Patients can shed their virus asymptomatically. Back in the day, we used to learn about the Zank smear. Now, more commonly, this is diagnosed by viral culture and PCR. These patients can be initially treated. These patients can either be treated episodically, so when they have a flare or lesions that show up, they can self-treat with a course of acyclovir or valcyclovir, or some patients will be on daily suppressive medications. The Ellsberg syndrome is actually something I first saw as an attending, which is acute urinary retention secondary to radiculitis and myelitis from HSV2. These patients present with acute urinary retention. It's pretty self-limiting. It takes a few weeks. It's reassurance. Of course, acyclovir or valcyclovir, times voiding, and these patients can be taught how to intermittent cath until their infection clears and they recover their own ability to empty and void on their own. Haemophilus decree, it's a painful ulceration. Again, usually on lesions are kissing lesions, so on opposing surfaces, the thighs, the labia. It's usually treated with azithromycin or ceftriaxone, and again, all sexual partners in the preceding 60 days have to be treated. Syphilis is caused by treponema. It's a single painless indurated ulcer. There's many screening tests and then confirmatory tests. Syphilis is treated with penicillin, even in women who are pregnant women who are penicillin kind of allergic. They must be treated with penicillin. Lymphogranuloma Venerum, also caused by chlamydia trachomatis. It's a single painless ulcer. It's usually treated with doxycycline or azithromycin, and the course of this treatment for this bacterial infection is usually 3 weeks. It's a prolonged course, as is the course of treatment for granuloma inguinale. Again, this is caused by different bacteria, Klebsiella. Classic question or histologic finding is the Donovan bodies, which are the rod-shaped organisms within the macrophages. Again, this is treated with azithromycin or doxycycline for a 3-week course. Genital warts are caused by human papillomavirus. Serotype 6 and 11 cause 90% of genital warts, and other serotypes are most commonly associated with neoplasia. Incubation period can be up to 3 months. Usually it's asymptomatic, usually it's a painless wart. You can get giant verrucous condyloma acuminatum. A lot of times you'll see the coilocytes on microscopic or pap smear. You can do PCR. Some can resolve spontaneously. Others can be treated with topical solutions or topical creams. Larger lesions can be removed with surgical excision. You can use a CO2 carbon dioxide laser, cryotherapy, even electrocautery with a little bovie. Gardasil is it's not new anymore, but it's the quadrivalent HPV vaccine. It's indicated in males and females aged 9 to 26, but actually even older individuals can get the vaccine to decrease the risk of cervical cancer and genital warts. Trichomonas is caused by a parasite. It's usually patients will present with a frothy white, green, or yellow discharge. The whiff test is positive, and this is commonly treated with flagyl, metronidazole. Molluscum, again, it's a pox virus. They're round papules with central umbilication. Pubic lice, no one wants those. Bacterial vaginosis, again, most commonly treated by the gynecologist, but I will tell you, you will see it. They will come to you. Primary care doctors refer everything to you as a urologist. It's the clue cells are what you'll see on the wet mount. Again, those are positive whiff test, and most commonly treated with either oral metronidazole or vaginal suppository. Those patients with recurrent bacterial vaginosis will be treated with boric acid. Yeast infections, Candida albicans can be treated again with oral fluconazole or vaginal suppositories. And the last thing is HIV and AIDS. STIs increase the susceptibility and risk for HIV, particularly herpes. Us as urologists will see some of the potential HIV and HPV related risks, including squamous cell carcinoma of the genitals, testicular cancer, epididymitis, erectile dysfunction. The patients will present with proteinuria related to their HIV, related to their heart therapy. And so a few things that we'll see is Kaposi sarcoma caused by HSV2. It's a cutaneous sarcoma, which is usually treated with local therapy. Of course, heart therapy. Patients who are on protease inhibitors, we may see and treat for stones. And this is kind of just something that we'll see at some point. In summary, GU infections are high yield material for your exam, for your career, and of course in life. Important for the exam is that you get a good night's sleep, no night before or morning of crash studying. You should have a good breakfast. Make sure you read the entire question and all of the answer choices before you answer your question. And if you don't know an answer, don't sweat it. Move on to the next question. The only other thing I'll say is when I was studying for my in-service exam and my board exam, I used this book a lot. It's a urology in-service and board review book, and I kind of made this my Bible. And as I read through the AUA guidelines and as I read through the AUA updates, I kind of just found the chapter in the book and made notes on the side, and it became your one Bible that I used to study as I went through my board exam studying and my in-service exam studying, and I still use it to this day as a reference guide.
That's great. Yes, I use that book also still.
Yeah.
So yes, doesn't look like there's any questions that have populated yet in the chat, so we can kind of move on to the questions. If people want to try to post answers to the questions in the chat, you can, and we can move from there and discuss the answers. Oh, I'm sorry. I thought maybe, okay.
I had them and I took them out because I thought there was not enough time.
No, no worries. Yes,
Okay.
I mean, that was an incredible amount of information, and like you digested it in such a concise and high yield format. I think that each one of those slides could also be made into a flashcard where people
Right.
could rapidly just absorb the information. So thank you so much. That was superb.
Thank you.
I have a question. How often do you screen for ureaplasma or mycoplasma in patients that present with mostly just dysuria, irritative, kind of voiding symptoms?
I will tell you, especially in young sexually active females, everyone gets, and who are coming to me with recurrent UTIs, everyone gets tested for mycoplasma and ureaplasma. And I would say maybe 70% of the time it comes out positive, and once I treat it, their symptoms resolve.
Okay. Oh, great. I mean, that's an important point because sometimes those patients, because they have a negative culture, could be kind of chalked up to pelvic pain or bladder
Exactly.
pain syndrome type of patients. Okay. Well, actually, this is our very last lecture of the in-service review series. So thank you for giving us such a wonderful end to the series. Oh, it looks like someone just posted something in the chat. Okay, basically the person is asking about videos that are archived, including the video of this lecture. So this lecture will be archived on the New York Section AUA website under the Empire Lecture Series. So you'll be able to access this lecture as well as all the other ones via the website. And I want to thank Dr. Husain again for that wonderful review. I enjoyed it very much. And I am going to flip us over to my screen for a second. Give me 1 minute. Right here. So for those of you watching, the New York Section Board of Directors was kind enough to basically send all the residents in the New York Section a gift in honor of this, relatively difficult year we've been having, the setting of recovering from a pandemic, which has the Empire Series logo and New York Section logo on it to kind of commemorate this series that brought us together during the pandemic and continues to unite us as a section. And since this is our very last lecture, I want to thank everyone who's contributed to the Empire series, and in particularly this most recent in-service review series, starting with Ms. Michelle Paoli. Everyone in the New York section knows her name. She is the executive director of the New York section, and she really keeps our whole section together. So thank you to her for organizing everything. Dr. Louis Cavusi, who is the current president of the New York Section Board of Directors, and Dr. Amanda North, who's a representative on the board, for supporting this series and helping us select the speakers and continuing to support these endeavors. We want to thank all of the residents and attendings who contributed to the Empire team, including Dr. Alex Small, who's an attending at an affiliated hospital at Mount Sinai, Dr. Akil Seiji. He is a PGY3 resident at New York Medical College, and he's actually responsible for editing, posting, and maintaining this YouTube channel, which is really a wonderful resource for studying. I think a lot of students and residents are using the videos and studying at their leisure, cross-referencing with the text. And thanks to him, we have all these lectures archived. I want to thank Mike Smigelski, Miad Movasaji, and Ezra Margolin, who are Columbia residents and who all participated as hosts and creators of the Empire series. And finally, I want to wish everyone good luck on their exam. I think Dr. Husain's advice was all correct. Get a good night's sleep, eat well, don't cram. And I know that everyone will do well.